Good morning, or I guess good afternoon, everyone. I'm Aaron Levo, the Vice President of Communications and Public Affairs. Happy to be with you on this Friday edition of our HHS Virtual Town Hall, an opportunity for us to get some updates on some really important stuff that's happening across Hamilton Health Sciences and in the region we serve, and also to ask questions, and most importantly, to also celebrate some of the things that are happening that we know about and we want to share a little bit of news about. So there's a series of presenters today. Our usual format is in play. So we will have some updates in a moment. Then after that, we'll have a Q&A session, and you can use the raise the hand feature in the participant section or the Q&A box. So ask your questions in writing using the Q&A function. You can type those in whenever throughout the presentation. And we have some that we're already submitted ahead of this meeting that we can address too. So first off, I'm going to turn it over to our President and CEO, Rob MacIsaac, who's going to give us a bit of an overview of what we're going to hear about today. So Rob, over to you.
Thank you very much, Aaron, and good morning, everybody, and welcome to this week's Town Hall. We have a few things to cover today, including, kind of an exciting update about our Hospital Information System Renewal Project, which I believe Dr. Barry Lumb is going to share with us. As always, I'll take a quick moment to simply say thanks to all of you for your ongoing efforts to help keep our hospitals, our patients, and each other safe throughout this pandemic. Last week, I participated in a news conference with our partners at the City of Hamilton and Public Health about the state of COVID-19 in our city and region. As we move deeper into what is normally the kind of cold and flu season, and as COVID rates rise in the city and surrounding regions, we need everybody to do their part to help us contain the spread of the virus. Our healthcare resources are so precious and health professionals are stretched so thin. And of course, hospital beds are at a premium. So at current escalation rates, we simply can't afford to absorb a second wave of COVID-19 while continuing to offer all the services that others rely on us for. If you have an opportunity, please remind your family members, friends, neighbors of the importance of adhering to public health guidelines. I think, each and every one of us as an employee of Hamilton Health Sciences has a kind of leadership role to play in the community with respect to these things. I do think it's worth acknowledging that we haven't had an outbreak at Hamilton Health Sciences in a number of months. So, touch wood, I think that is a testament to everybody's commitment to following the guidelines around masking and hand washing and social distancing within our hospital. We should never take for granted that achievement. And if you look at London Health Sciences today, they have 6 floors of their hospital in outbreak. And so it's such a stark reminder to all of us of the need to continue to be vigilant when it comes to observing public health and IPAC guidelines for the virus. So congratulations for all that you've been able to achieve, but please keep up the good work. Please keep up your commitment and vigilance, because it's just so important for all of us and for our community. So now I'm going to take a moment to turn it over to Sharon Pierson, our new Executive Vice President of Clinical Operations and Chief Operating Officer, for an update on the state of our hospital's operations. Sharon, over to you.
Great, thank you, Rob, and good morning, everyone. And Rob provided great context really for this capacity update today. There's been so much in our local media and provincial media around the state of hospitals right now in Peel, the larger GTA, and then as Rob mentioned, to the Southwest region. So, we've seen lots of different strategies having to be considered, including how staff can help across hospitals, how patients might need to move across the system. So really timely that we're talking today about our own capacity at Hamilton Health Sciences. So just a few metrics to put some context around the conversation in terms of how we're faring with our occupancy as we near the end of November. At an aggregate rate, we sit at 99%. Of course, the devil's in the detail always across our sites. And if we were to look at our acute adult sites, we'd see much higher rates, with the Juravinski sitting closer to 110 and 115 some days, and certainly the Hamilton General not far behind. So, extremely pressured sites that we have amidst HHS. Most concerning is that we are not back to our pre-COVID numbers as it relates to our emergency volumes. Concerning for a number of reasons. One is that we're already at capacity, and two, and most significantly, is that what we're hearing from our clinician partners is that patients are delaying those visits to the hospital or to seek assistance from primary care. And we've been having this conversation at some Hamilton tables about the fear of patients and families to come to hospital or go to primary care, and that's having some negative consequences. So some work to do to really encourage individuals to come to hospital and primary care when they need to. Certainly, as Rob mentioned, it's pretty precarious, the situation that we're in from a capacity perspective, and our ability to manage a significant wave 2 volume. Certainly couldn't do it while we continue to try to ramp up to our pre-COVID wave 1 situation as far as our scheduled care. We do have plans in place as to how we would surge, using a lot of our unfunded spaces across our organization, opening up new unfunded space. We know that much of that will be contingent on our human resources, though it's a big stretch for everyone currently, and we know the pressures that would exist should we need to do it again. So to Rob's point around all of us stressing the importance of adherence to the guidelines, and Rob talked about his message and public health doing the same. And I was watching early news this morning and saw those huge lineups for Black Friday around the malls, with many individuals that are in red and lockdown coming out to other communities. So it really is concerning what the impact of that might be. And so again, just stressing that importance that we all follow those guidelines. Go on to the next slide. In terms of where we're at with our surgical and ambulatory activity, we are almost back to our pre-COVID levels for our ambulatory visits. And the vehicle, or our ability to do that, has been really the expansion of our virtual care capabilities has been so impressive. So we're sitting, it's actually closer to 37% right now of our activity occurring virtually, which is really, really impressive, and allows us to be able to see those patients that it's so important that they are seen in the clinic to maintain their health and not have to come to hospital. In terms of our surgical procedures, we're sitting around 85% of our pre-COVID levels. And really the primary reason for maintaining that 85% is back to that occupancy we just looked at. The bed demand, should we go up to 100%, would be significant, and we don't currently have that capacity. So we are having to monitor the occupancy rate and make that determination of when we can ramp up, and really watching the trends in the communities like what we're seeing in the Southwest and the GTA, because equally we need to have those plans in place to ramp down. I'll just go on to the next slide, because it's a little bit better news in that how we might get there is that we do have the good fortune of having a satellite health facility in Hamilton. So as we talked about at our last town hall, we had moved our first 30 HHS patients, and they're all settled in. And St. Joe's was a couple of weeks behind, but they've also moved in 30 patients. We do have plans as of right now. It's tentative, but pretty close to solidifying the second week of December for the second 30 patients to move into the AHF. So we're really fortunate that the ministry supported this, and we have this capacity opportunity for us. It has had a consequence on our ALC rate, which we're very pleased about. I would just modify sort of our excitement over that, though, because we still have close to 200 ALC patients spread across our organization. And we know there's incredible pressure in the community right now to be able to accommodate the volumes of alternate level of care that are in the acute sites. And if we go to the next slide, I'll just talk about that status of where we're at with long-term care, because really these congregate settings continue to be the hardest hit through COVID. And Hamilton is not unique. We have about 12 outbreaks in the city right now. Some of those are very substantive and some of them have gone on considerable time now, which is of concern. We do have strong partnerships with the long-term care and the other congregate settings. As a hospital partner, we are calling them almost daily to check in with their staffing. Do they need help with IPAC? Can we support them in any way? So really trying our best to provide them the supports they need to care. We also have strong partnerships now with our GIM, working with primary care and the medical directors in the homes as well, which is an additional support for them. We do continue to look for volunteers. We are very fortunate to have a number of volunteers, many of you on the call, who have come forward and offered to help in these situations. We continue to replenish that pool. I've added the website here. If anybody has any questions, happy to talk to anyone, happy to link anyone to someone who has gone into the homes so that they can share their experiences. But it really, it's an amazing contribution that we can make from acute care to be able to support our congregate partners where we see such concerning outcomes from COVID in these homes. So with that, I will stop my operational update, but happy to accept any questions through the chat or later on. Thank you.
Yeah, thanks very much, Sharon. Great update. And now, as is our habit, we'll turn over to, we're very fortunate to have Dr. Dominik Mertz to give us an overview of the epidemiology of the virus in our community.
Yeah, thanks, Rob. And I was asked as well to talk to the Ontario COVID-19 response framework today and what it means for us in a hospital setting, or what it doesn't mean, and where we stick to our own rule. Next slide, please. So starting off with the epidemiology, and this is the slide you're, in the meantime, probably pretty used to. If I was standing here a week ago, I would have said I'm carefully optimistic that cases are actually coming down. Now, this week looks more like we are back to where we had been 2 to 3 weeks ago. So certainly, again, on the wrong trend right now in terms of what our case numbers are doing. I don't think I go any further back here. You just see when you're looking from, I would say, beginning of September, there's more or less, I would say, a linear increase in number of cases over time. It's not exponential, but it's linear at this point of time. And we haven't seen a clear plateau yet in Hamilton. It's just more like up and down from week to week. Next slide. These are our unlinked cases per 100,000 per week, which we are watching very closely in terms of our policy decisions. And you see that Hamilton and Halton are, as well as Brand, are in the same ballpark of 13 to 14. Haldimand, Norfolk, and Niagara are lower. All of those public health units would have had better results a week ago. So it's across all the public health units surrounding us as well that there's been a trend from last week to this week for the cases to increase. Next slide. Which brings us to the response framework. And as you all know, Hamilton as well as Halton are currently in the red, which is the control or stringent measures category. And this was based, when you're looking through all these criteria here, when the decision was made, we had a weekly incidence of total numbers of cases of 40 or more. We had a test positivity above 3%. We had an RT of more than 1.2. We had an RT of 0.85 last week. This week, probably more, again, in the range of 1.2. So more cases being infected than we have current cases walking around in our community. We continue to have repeated outbreaks. We see an increase in those non-linked cases, which is the metric I've just shown you. We see a certain strain on our healthcare system, as Rob as well as Sharon alluded to. And public health was struggling as well. They now have more contact tracers, and they were actually very nicely able to catch up with the contact tracing over the last week. Now with more cases, we will have to see whether they continue to be successful in tracing the contacts and informing the contacts within 1 to 2 days, which is the overarching goal. Next slide. So as I said, we are in control, and on the next slide, maybe we skip this one. I just listed some of the public health units. As you probably all know, Peel and Toronto are currently in lockdown. Discussions are whether maybe York will be added today. Hamilton, Halton, Waterloo are in the red. When looking at our surrounding public health units, Brant, Niagara, Wellington, Dufferin, Guelph are in the orange, and Haldimand, Norfolk, hard to read, sorry about that, is currently in the yellow. Next slide. Now, what does that mean, being in the red? And you probably are quite familiar in the meantime with what it means. And I just, in the document, you would see for every sector what it means in terms of restrictions. I just show you a couple here that are most relevant to our staff. Here, social gatherings, as you know, we are down to 5 people indoors. If you have a larger household, like myself, then you can have more than 5, but it must be within the household if you exceed the 5, and 25 people outdoors. Next slide. Then for meeting and event spaces, and that's been a frequent question that we had been asked since we entered the red zone of this framework. Are we still allowed in acute care to have meetings of more than 10 people in the same room? As you can see here, the Ontario framework would restrict this to 10 people indoors or 25 outdoors. Next slide. Now, I would say the simple answer is hospitals are not affected by the framework. There's no direct bearing on what we are doing in a hospital or long-term care institution. And our maximum of people is still based on the capacity per room. And that's a concept you're all familiar with. It's going back several months now. All of this being said, the higher our baseline or background epidemiology, the more important it is to avoid any unnecessary, in particular large meetings, and hold meetings virtual whenever possible. And I'm in particular thinking about meetings of research teams that really don't have to meet in a single room. They aren't not necessarily at the same site to start with. Just hold those meetings virtually. It will reduce otherwise unnecessary risk. Next slide. And we have several decisions or policy changes potentially ahead of us if we see a further increase in the unlinked cases per 100,000 per week. Why are we looking at unlinked cases? Because it's the best metric, I would say, that represents the risk of a random person walking into your organization. If you look at overall cases and you happen to have a large outbreak somewhere which is well contained, you have a huge increase in total of cases. It doesn't mean anything to you. On the other hand, if you don't have any outbreaks but a lot of unlinked cases in the community, it increases the risk for each staff or patient coming in to actually be infectious. And those things that we would implement in the next step, and there's background work happening these days to get ready for that, to look at lab capacity to be able to do so in terms of testing of any transfer coming into HHS. Patients undergoing chemo and radiotherapy would get tested repeatedly, and procedures, so in particular surgical procedures that require general anesthesia would get tested again as well once we hit the threshold. We will again advocate then for N95 for all aerosol generating medical procedures, and we have to revisit the rounding models as well, trying to reduce again the number of people that huddle together and may potentially infect each other. Next slide. Okay, that's it from my end for now. Also happy to take questions at the end of the presentations.
Okay, thanks very much, Dominik. So again, we will have questions afterwards. We'll move on to Dr. Lumb, who is going to share with us the current status of our project to implement a new hospital information system. Barry, over to you.
Thanks, Rob. Hi, everybody. Back again. And thanks for your attention. Some of you may have heard the comments by Glenn Geiger, the Chief Medical Information Officer from Ottawa, at the leadership event on Tuesday. So if there's a little bit of duplication, I apologize. But I think Glenn's comments about the reasons that we're undertaking this project were really very important and very relevant. And obviously, the first and most important piece of this is our patients, and that we're going to improve the quality of the patient experience, provide them with a seamless transition from one area of care to the other, not only at HHS, but at St. Joe's and as we further expand out into the community. So there'll be a single source of truth that allows the patient to not have to repeat their story over and over again, and where the providers will know exactly what happened to the patient wherever they happen to touch down in the hospital sector and later in the community. We want the experience of our providers to be improved and to make it easier for them to do their job and to feel like they're doing their job in a safe way that's best value add for the patient. We want to absolutely take advantage of the incredible technology to improve the quality of our care, patient safety, and all of the aspects of the journey that will be enhanced. We want the opportunity to exploit the incredible research opportunities of the EPIC system. And we're very keen that the EPIC implementation at HHS will allow us to expand out into the community and really start to address some of the really important population health issues that we're all aware of in our community and beyond. So you've heard us say over and over again, this is the biggest clinical transformation project that HHS has and likely will undertake in this generation. And it's going to involve change management like we've never seen before. It's change on steroids, and it's going to be massive. And we still believe, now that we've signed our contract, that we will be in a position to go live in June of 2022. That seems like a long time from now. It's not. It's going to be a massive amount of work. And to repeat myself again, the success of this go live is absolutely going to be dependent on the work that we do ahead and what you guys and everybody else in the institution is willing to put in to get us ready for that moment sometime in the wee hours of a day in June, where the switch will be flipped and we will no longer be a paper-based institution. Every aspect of patient care will then fall under the HIS. And so it's going to be a very big day. It'll be chaotic. We know that. Everybody will be saying, oh my goodness, but we'll get through it. And a month or so later, we'll be well underway. Next slide. So you may have heard, and you will continue to hear now, that we were fortunate with the help of our board to sign a contract with EPIC. That contract is based on the work that St. Joe's did with their RFP a few years ago, but I want to emphasize that this is our own instance of EPIC. We are going to be doing this as an HHS project in cooperation with our colleagues, but it is our own single and separate instance of EPIC. There's been an immense amount of work that's been undertaken already, and I have to say I'm continually struck by the amount of work that's already underway. We've done a lot of work on pharmacy, ambulatory care, and hardware in terms of readiness. We know that these are critical pieces of the implementation, and we want to be absolutely certain that now that Epic is directly involved, that we're as ready as we can be to start that work. You'll also be aware that we are starting to reach out to certain areas within the hospital to do some further work on understanding the current state. The EPIC project really focuses on the future state, but in order to do that in certain areas, we really need to have a clear understanding of how the operation is happening currently. And so many of you, and especially leaders, will be hearing about requests for the team that we've hired to come in and start doing some current state assessment work. We have hired now almost 100%, well over 95% of the folks we need to get the project up and running. The analysts and all of the project managers and so on are in place, and they have actually been working already for several weeks. Next slide. So the hires are almost done. Those folks have now had 2 sessions of onboarding. There's another one for a smaller group on Monday, and then one last onboarding group to go. Carrie Cassell and her team have done an absolutely amazing job in onboarding and bringing all of the folks up into, at this point, the virtual team that they are. They will be completing not only their training, but also certification processes along with their EPIC colleagues, so that come January, the actual process of implementation and project development will be fully up to steam. A couple of cool things. We are going to name this project, and through Aaron and James and his team, we will be undertaking a naming exercise and voting within the institution, and there'll be a plan of announcing that along with a formal kickoff event sometime in mid-December. I will tell you that EPIC takes this thing pretty seriously. So we told them, I think it was Tuesday, and on Thursday they had already assigned 4 people to our team, including the 2 leads, and we've already met with them. So we are full steam ahead, foot's on the gas, and we're into a really exciting time. That's it for me, Rob. Thanks.
Okay, yeah, thanks very much, Barry. And Aaron, we'll pass it over to you to moderate the Q&A.
I am ready. Are you ready, team? Let's go. Okay, so maybe Barry, I could throw you a question right off the top. This is super exciting, as you said, change on steroids, but that change, you know, it has an end state that's going to be pretty amazing. I'm just curious if you could, in all the work that's been done looking at EPIC installs across North America, even worldwide, is there something that stands out to you? Like when you see what a hospital is capable of doing after installing this product and having this clinical transformation take place, what can we look forward to? Any anecdotes?
Yeah, I think it's really important that we, and thanks, Aaron, like this will change everything we do about the patient care, but what it's also going to do is allow us to be integrated with our partners and also internally reflect and study the care that we do in order to be able to really make changes in quality and patient safety. So it's about getting past the technology to launch this clinical transformation, which 3, 4, 6 months out will then allow us to really start to examine ourselves in cooperation with our colleagues about what we can do better.
Well, we'll certainly have lots more to unpack about that in the months ahead, and I'm really looking forward to that work. So very exciting news for all of us. I do have a question here about the vaccine that was submitted ahead of time. I guess the general question is, would hospital staff have to take a COVID vaccine? I think Dr. Dominik Mertz, you and I talked about this earlier, that it really wouldn't be a mandatory. Like currently, do we compel people to take other vaccinations?
Yeah, I wouldn't envision this to be mandatory, certainly not at the hospital level at this point of time, and I haven't heard any rumors that the province or the federal government would make any vaccination for the COVID vaccine mandatory. And to add to that, I think at this point, we don't necessarily know yet whether the vaccine actually prevents transmission. What we know from the data so far is that you're much less likely to get sick, which is awesome, which is what we need, right? If you get the vaccine, you're 90% less likely to develop symptoms. That's what we know. We don't know yet whether if you get vaccinated, whether you're able to asymptomatically transmit nevertheless. And only if that latter would actually be the case, then you can make an argument that something like this may need to be considered to be mandatory. But we are far from that. We don't even have the data at this point of time that would justify making the vaccine mandatory.
Good stuff. Another question here related to that. Well, I've got you up. Like, what if it's not going to prevent transmission? Like, what's the timeline for that to have a positive impact in our community? From, you know, right now we're hearing a lot of news, even in the newspapers. I think the last 24 hours about a potential approval before the year end. Like, when that happens, what can we look towards and expect to see any difference in what's happening?
If I knew that, I would probably know more than the Prime Minister at this point of time. It seems to be very unclear how quickly we will get the vaccine available, right? One piece is to get it approved, and it looks like we are well on track to do that along with the FDA and the Europeans, which is very important because then you open the market for the vaccine in your country. So it's very important that this happens, that this review happens quickly. And based on the data that had been shared in the lay media, it looks like it will be approved at that point of time. But then the big question will be, how quickly do we get the vaccines? How quickly do we have them available? The estimates at this point is first quarter 2021, and maybe as early as January. But how many million of doses we are looking at is so unclear at this point of time. So it's very hard to say how quickly it will change anything for us as a community. And I would envision us to continue with social distancing and masking for many, many months to come.
Gotcha. I think, Barry, there's a question in here about the readiness work around ambulatory. I think maybe that was something that you mentioned. Can you expand on that? The question is just, what do you mean by readiness work?
Thanks, Aaron. This is really very specific work in order to understand our scheduling and registration processes, and to try to determine when and if we would go to some form of central registration versus scattered or widespread registration opportunities. So it's very specific ambulatory work that we're doing in the readiness. The ambulatory piece of the HIS implementation is a huge part of the project, and there will be separate working groups specifically addressing various aspects of the ambulatory process as we go along. We will likely be standing up our work groups, of which there will be literally dozens over the next 2 to 4 weeks, so that we can get up and running in the early new year.
Perfect. And can you also then, the Deloitte readiness assessments, how does that fit into that work?
So that work, the scheduling and registration piece was done, sorry, my phone's going, it was done as part of the Deloitte work.
Understood. Thanks very much for that. I'm going to move to a next question. Before I do, I just want to highlight for some of my clinical leadership colleagues on our panel today, there's a pretty detailed question regarding AGMPs that's in the Q&A box. I don't know if I have the right people to answer that question or not, but maybe if you could take a look at that, and if someone wants to put their hand up for that, then we can answer it live. If not, then we'll defer that one to someone who's more who has more knowledge in that area and can give us it's a detailed question. I want to give a detailed answer. So take a look, and I'll move on to the question here about another one about Epic, Barry. For Epic, there's 2 children's hospitals in Ontario, Sick Kids and CHEO, that have recently moved to Epic. Will McMaster Children's Hospital have the opportunity to connect with those children's hospitals to improve transition points and patient experience?
Yeah, Excellent question. Thank you, whoever asked that. So you may have heard me talk about the amazing, what they call interoperability opportunities of the Epic world, where one institution can connect and understand the care that's going on in the other. This is one of the reasons that we're so comfortable that we'll be able to have our own instance in Hamilton and still provide a seamless opportunity for patients who move back and forth with St. Joe's. The absolutely same thing applies to sick kids and CHEO. We can connect them through the interoperability opportunities of Epic, and patients would be able to move back and forth with no difficulty.
Good stuff. Thanks for that, Barry. I have another question about Epic here, but before I get to it, just also wanted to point out, I don't think I have someone from HR with us today, but if we do have someone who can take a look at the question about the Staff and Education Development Fund reopening, then that would be great. If we don't have someone who can answer that appropriately today, then for sure we'll follow up with you, Brendan, by email. Also, just want to point out to the anonymous attendee that asked about the AGMPs, Dominik Mertz has offered an answer to that question, but given the length and detail that's required, thought that it best you reach out to him directly and he can have a chat with you about that. So Barry, next question about Epic is, will all hospitals in Hamilton be using the same version? I think this cuts to what you just said about interoperability, is it not?
Yeah, so St. Joe's will have their instance, their install of Epic. We will have ours, but part of that build and getting ready to go live, we will develop the interoperability connections with the St. Joe's install and our other Epic colleagues, and indeed maybe even some of our non-Epic colleagues, so that at the time that go live occurs, that will all be built in and ready to go. It won't be something you have to ask for, it will be there.
Good stuff. Here, a question from Stacy about at what point will the hospital decrease in-person appointments and increase virtual appointments, especially in our more vulnerable client populations as cases of COVID continue to climb? I think that work has been occurring and is underway. Not sure who's best positioned to address that. Maybe Sharon, you could give us some insight into where we're at, and that it's an evergreen process, is it not?
It is, and certainly I don't think Bruce is with us today. Bruce Squires is leading the ambulatory task force, but that's something that task force is monitoring closely in terms of where we would see a further increase in the virtual visits. We know that we have wanted to have some of the patients come back in person. It's important for that assessment. We do see areas like the Center for Healthy Aging where we see the frail elderly have very low rates of in-person visits and more virtual. So we are trying to modify and really look at the clinics on a population basis. So that monitoring is in process.
Wonderful stuff. Thanks, Sharon, for that. I just want to point out to anyone that wants to raise their hand in the participants box, you can ask a question live. We did receive some questions ahead of time. I'm going to go to another one of those now. Just maybe Kelly Campbell, I can ask you to respond to this question. It's about the TerraCycle program. Are we expanding that into new areas of new PPE, I guess, more boxes to support that?
Yeah, so two different questions. Yes, we did expand it beyond the original mandate, which was just surgical and procedural masks. So there's been a whole list of other items that can go into the TerraCycle box, including things like face shields. We are working with TerraCycle. Their boxes are in demand, so it's taking longer than we would like to get additional boxes. And I know the team is working on a plan to disperse those. It's not just getting the box onto a clinical unit as an example, but obviously it's the process to retrieve the box and replace it when it's full. So that's a whole nother process that has to be developed on top of people's regular standard work. So the team's working through it.
Wonderful, thanks for that. So I'm gonna guess one last call for questions. I'm sorry, Brendan, we don't have somebody to answer your question about the Staff and Education Development Fund right now, but I'm gonna make sure that we follow up and get an answer to you about that. Similar question came through in the submit in advance questions. So we'll make sure that we get that posted. There were, I think, about 2 other questions in the questions submitted in advance that we didn't get to today, just in terms of the content expertise required and the ability to give a good, thorough answer. We couldn't do that live today, but we'll absolutely get that answer and get it posted on the hub, as is our normal practice. Perhaps one last call out for questions, either live or in typing format, and then we'll go to our celebrations. Going once, going twice. Okay, well, thanks everyone for participating in the Q&A section. Again, we'll follow up where we've missed details for someone in particular. So Rob, perhaps you want to lead us through our celebrations.
Yeah, thanks, Aaron, and maybe you can stay online with me, and we'll do this together. As always, we know from our work in resilience that gratitude is an important part of maintaining a level of resilience as we work through this very slow-moving emergency. Feels like a marathon, and I know it's taxing everybody, but one of the things we can do to combat that is to be grateful for all of the things that are good in our workplace. And so maybe I could kick it off by saying that we recently wrapped up our annual Workforce United Way campaign. Firstly, thank you to everybody who donated to that campaign. Together, we raised about nearly $75,000 for the United Way. This includes 350 new signups for payroll deduction. We raised the most money ever through direct employee giving. I also wanted to really extend my most profound gratitude to the United Way Campaign Committee for all of their hard work, for doing this despite the fact that the traditional events that we've had, in-person events, couldn't be held this year, but notwithstanding that, we were still able to raise an appreciable amount of money that goes into our community and helps so many people. So thank you to everybody on the United Way.
Good stuff. And so you can make a celebration by typing in the chat forum, and we'll read it out loud. You can also raise your hand in the participants box, and we'll call on you to issue your celebration on your own. So seeing here from Carol Langdon, sending a big celebration and thank you to the Leadership Planning Committee and speakers who share their knowledge, insights, and experiences. Oh, it just moved on me, sorry, let me finish that. And experiences over the month of November, much appreciated. Couldn't agree more, Kara, great shout out. That was really well done this year, shifting to a virtual format, and some really insightful commentary from the panels and from the speakers, so good stuff. Oh, I see it. Rob, did you want to do this one from Deb Bedini?
Yeah, so from Deb Bedini, congratulations to HHS, Dr. Corey Sawchuk, Dr. Maureen Mead, and the critical care teams for their collaboration with the Trillium Gift of Life Network. We will be receiving 2 awards, the Provincial Conversion Rate Award and the Award of Excellence at a virtual award ceremony next week. So check the dispatch for details. Hamilton Health Sciences is consistently such a high performer in terms of Trillium Gift of Life. It's it's such commendable work and challenging work, but also work that makes such an immense difference to people's lives. So that's a great shout out.
Good stuff. I see here from Kelly Campbell, thanks to all the staff and leaders that helped to open our stem cell inpatient unit yesterday at the Jaraminski Hospital Cancer Center. Amazing. And for those that got to attend that event, opening that's a really wonderful milestone for us for that program for sure.
Aaron, can I add one?
Sure.
It might seem a bit odd actually, because it's thanking our community partners, but I had opportunity to meet with a provider from James Street North yesterday, and I think the work that those in the community are doing to try to help the hospitals and offer services during this time is really commendable. They're very interested in how they can help, how they contribute, how they make a difference. So, it'd be difficult to call them out on all of them by name, but I just wanted to acknowledge that behind the scenes, there's a lot of individuals really trying to help.
Right on. Thank you for that, Sharon. Here we have one thank you to the screeners who are working hard to keep our hospitals safe. They have a very challenging role, and in many cases are going above and beyond to support our patients and visitors. We are so grateful, from Katie Ferguson. Thanks, Katie, for that.
And, just along the lines of what Sharon was saying, and I know there's been some negative press over the past week from the Auditor General in terms of the response to the pandemic that the province has led. But I think it should be said, notwithstanding the AG's comments, that hospitals across HNHB have come together and worked so well together to develop response plans for the pandemic. So it's been a pleasure to work with those other hospitals and to see the collaboration that's gone on.
Good stuff. And Dr. Kelly, I see you have your hand up. Can you go ahead, please?
Yeah, thanks, Aaron. I'd just like to say we've got a new model, Surgeon of the Week model at the West Lincoln Hospital for general surgery services out there, which is now its fourth week, and just a phenomenal resource. Everybody coming together, both from the Hamilton General and the JH sites, but also for the West Lincoln site, just welcoming those surgeons. And really, it has really given a boost to the hospital there. And I know the local family docs and the emergent referrals coming into that site, and with the opening up of the 2 ORs now, which are fully functional with general surgery, gynecology, plastic surgery, and orthopedics. I think that's just been a really fantastic effort by everybody involved. So I'd just like to thank everybody for that.
Good stuff. And I hear you've been out there too yourself.
I have. It was great experience.
Good stuff. I see here from Kelly Campbell, shout out to our site logistics teams that work hard to keep all units and departments stocked with the necessary PPE to do our jobs for sure. Even here, I'm at our King West office today and was able to pick up a mask right at the door. Hand sanitizer is fully stocked. It really makes the experience of being here feel great. So thank you. Any others from our panelists, from our audience? I see, Judy Baxter, shout out to all the new units who have started to implement the next wave of CQI. For sure, we've achieved an enormous milestone across the organization for CQI, a ton to celebrate in terms of that, not just in terms of improvements, but also units onboarded. It's amazing when you think of the work that's happened over the last 5 to 6 years. Okay, Rob, well, maybe we'll give it to you to close us out and send us off on a Friday afternoon.
Okay, thanks, Aaron. Good job. And thanks, everybody, for being here today. I think it's a great opportunity for us to tell you a few things about what's going on and for people to kind of dig in or ask questions about what's important to them. So really appreciate your attendance today. As I stated off the top, thanks very much for all that you're doing to help us get through this very challenging time. And I hope people have a restful weekend for those who have a bit of time off. So cheers, everybody, and we'll talk soon.